Dissociative disorders. Dissociation, which is the removal from conscious awareness of painful feelings, memories, thoughts, or aspects of identity, is an unconscious defense mechanism that protects an individual from the emotional pain of experiences or conflicts that have been repressed. This splitting off helps these individuals endure and survive intense emotion, physical pain, or both. Dissociation occurs as a result of extreme stress or trauma, such as war or abuse in childhood and adulthood. Individuals might develop post-traumatic stress disorder if the trauma is severe and lasting, which can lead to dissociative identity disorder. Everyone uses dissociation at times. For example, a person might be so engrossed in a book or a movie that they do not hear anything or anyone around them. But this is not a pathological behavior. Everyone forgets things or daydreams, but this does not indicate an illness. Abnormal dissociation states can become dissociative disorders when identity, memory, or consciousness is disturbed or altered. Dissociative disorders in the DSM-4 text revised are dissociative amnesia, dissociative fugue, depersonalization, and dissociative identity disorder. Amnesia is the loss of memory or the inability to recall important personal information. Recent amnesia can occur immediately after a traumatic event, such as a car accident. Localized amnesia occurs when the individual cannot remember what occurred during a specific period of time. For example, not being able to remember what happened for hours after a car accident. The ability to recall some events during a specific period is called selective amnesia. It is important to remember that patients are sometimes found by the police. These patients wander aimlessly and are confused and disoriented. They might be taken to a hospital and might be frightened and perplexed. The precipitating factor is usually something that causes severe psychological stress, such as a threat of physical injury or death. Sometimes amnesia is only partial and clients remain conscious of what happened, although they report that they feel no control over it. In cases of complete amnesia, the lost memories can be recovered under certain therapeutic circumstances, for example, hypnosis, or they may return spontaneously. Clients who have sustained a loss of their own reality may even adopt a new identity. It is important that you will conduct a careful assessment of the client's physical condition to rule out the possibility of any organic cause, such as a brain tumor. Many of the behaviors of clients with dissociative disorders resemble behaviors associated with organic conditions, including post-concussion amnesia or temporal lobe epilepsy. A psychological assessment is conducted to discover the fundamental source of the anxiety as early as possible. Treatment includes providing a supportive environment as those memories are retrieved, and this will help to restore the identity of the person. The major feature of dissociative fugue is sudden, unexpected travel away from home or some other location with the assumption of a new identity. This can be partial or complete, or a confusion about one's identity. The travel and behavior appear normal to casual observers. Thus, the person does not seem to be wandering in a confused state. Fugue states last from a few hours to several days. These episodes are usually accompanied by amnesia. Consequently, many patients do not remember what happened during the fugue state. Dissociative fugue is rare and usually follows severe psychological or psychosocial stress, such as marital quarrels, personal rejections, military conflict, natural disaster, financial difficulty, and suicidal ideation. Major depression is often present prior to dissociative fugue, and there might be a history of childhood trauma. The fugue state then allows escape or flight from an intolerable event or situation. When fugue ends, depression, grief, shame, and suicidal or aggressive impulses may appear. Efforts to restore pre-fugue memories often are unsuccessful, yet may help to maintain an identity if they are successful. Most fugues are self-limiting and do not require intervention. The major feature of dissociative identity disorder is the existence of two or more identities or personalities that take control of the person's behavior. The person or host is unaware of the other personalities, but often called the alters, but the other alters might be aware of each other to varying degrees. Patients can experience memory problems, depersonalization, derealization, identity confusion, time loss, and voices conversing with each other. Traditional views of this disorder consider dissociation to be a defense against extreme anxiety that is aroused in highly painful and emotionally traumatic situations, such as physical, emotional, and sexual abuse. The splitting off of these painful events allows the person to survive the trauma, but leaves an impaired personality with disconnected parts or alters. The alter personalities have feelings and behaviors associated with the trauma. Often the clients may have amnesia involving inability to recall any important information relating to the identities. This disorder is often associated with a high incidence of suicide attempts. And there's an array of symptoms which can resemble other neurological or psychiatric conditions such as depression, anxiety, panic disorder, and post-traumatic stress disorder. Each personality is different from the others and from the original personality. Each personality has its own name, behaviors, traits, memories, emotional characteristics, and social relations. The primary identity might carry the person's name and be depressed, dependent, and guilty, whereas the alternate personalities might be hostile, controlling, and self-destructive. When you see a sign that says, "You must not read this notice," you have a tendency to want to read that notice. That is the double bind. It's wrong to act, and it's wrong not to act. There's no escape, and whatever happens, it's your fault. The double bind is the formative dynamic of the multiple personality disorder. When daddy tells you that he loves you, you are special, but then he hurts you horribly. When you're told that your baby brother will be killed and you'll go to hell if you tell your secret. When you are instructed to honor your father and your mother despite their betrayal, and when you know that you are responsible for making these horrors happen, you're in a double bind. As adults, we've learned something about the world and how to handle life's contradictions. But when you're under 7, the double bind, repeated over and over, is a living contradiction that simply blows your mind. A shy, quiet woman might have an alternate personality that is promiscuous, flamboyant, childlike, and aggressive. A woman might awaken one morning and find the living room of her apartment littered with toys and empty alcohol bottles and leftover food. She does not remember what happened because she has amnesia for the span of time when another personality took over or came out. Sometimes a switch to another personality is preceded by a headache, or individuals might cover their face and eyes with their hands. For example, the patient or original personality might state that he or she hears voices talking to one another in his or her head. This might be misdiagnosed as auditory hallucinations, and the disorder misdiagnosed often as schizophrenia. These patients are admitted to inpatient psychiatric units when they are suicidal, meaning that an altered personality is trying to harm or kill one of the other personalities for revelations concerning abuse, or when mutilation or an uncontrolled impulse to harm the self are present. Severe anxiety or depression related to the coming out of upsetting alters might also be a reason for admission. The safe structure of a hospital setting provides emotional security for the patient when working with difficult or overwhelming problems. Treatment involves psychotherapy, hypnosis, cognitive behavior therapy, having the client maintain a log of their emotions for rational analysis. Often they'll keep a log of their different personalities. And then integration, which often is totally unattainable. It is the only way for symptom management and the reduction for only one option. The goal is to help the patient identify that there are other personalities present and to recognize when they come out. For some, it is very, very difficult. For others, they are able to identify the need for those identities and the purpose that they've served in their life. In depersonalization, individuals feel detached from parts of their body or from mental processes. Depersonalization involves an altered sense of self so that the individuals feel unreal or strange or believe that danger is not happening to them but to someone else. Therefore, as a response to an overwhelming stress, these individuals are protected from the overwhelming anxiety. Depersonalization can also involve feeling like a robot or feeling as though one is in a dream. It is often accompanied by symptoms of derealization in which individuals feel that the outside world is changed or unreal. For example, buildings might appear to be leaning, or everything might seem gray or dull. Usually it's associated with past exposure to overwhelming stress and then is resolved when that stress tends to resolve itself. Medications for anxiety and depression can be helpful if the patient is experiencing these symptoms. And then cognitive behavioral therapy is often used to assist with stress management. You want to provide empathy while allowing the client to discuss feelings objectively. The client and the family need education about symptoms and particularly identification of those. You want to remember that the person with this disorder remains oriented to person, place, and time, but has an altered sense of reality. They seem unreal to themselves when they look in the mirror, as if they're looking from the outside in. Nursing interventions for all dissociative disorders begins with developing that therapeutic relationship. Be consistent. Recognize mood and behavior changes. Watch objectively at their behavior. Create a safe, structured environment, providing milieu therapy. So provisions for a safe environment and a trusting relationship are basic for helping these patients. Many have never had a trusting relationship with anyone. Assisting with group sessions, providing emotional security, empathy, and acceptance and support helps the patients to cope with daily living and are all involved in their nursing care. You want to encourage attendance at community or group therapy sessions to decrease isolation and dissociation. Educate the family and identify their support system. And then encourage journaling to increase self-awareness, and that works for all the dissociative disorders. In general, with dissociative disorders, psychopharmacology is often ineffective. Anti-anxiety and depression medication can be helpful only for symptom management, but no medication has been identified to eliminate a dissociative disorder. Long-term therapy assists with integrating the disorder into the person's true self. Hospitalization is usually done during a crisis period, and milieu therapy can be task-oriented or art therapy. Psychotherapy is usually the most effective and combines psychoeducation, traumatic reenactment, journaling, and artwork. Pharmacological and integrative therapies can sometimes include IV benzodiazepines in the hospitalized patients, but only in an acute situation.